Okay, let's start. We were discussing about the facial bone fracture. We have already completed the mandibular fracture, condyle fracture, and now we are discussing about the midface fracture. The midface is also divided into two parts: upper midface and lower midface. So upper midface consists of upper midface is located between the occlusal unit and the frontal facial unit. It consists of the zygoma laterally, the NOE area centrally, and the internal orbits on lateral surfaces. So the midface is divided into two parts at the Lyphoid level. Below the Lyphoid level, it consists of it as a lower midface, and above the Lyphoid level, it called it as a upper midface. So upper midface consists of upper midface is located between the occlusal unit and the frontal facial unit. It consists of zygoma laterally, the NOE area centrally, and the internal portion of the orbits bilaterally. So the Lyphoid level divides the face into two parts: the lower unit and the upper unit. The lower unit consists of occlusal unit, and the upper unit consists of nasal bone, medial wall or orbital floor and lateral wall of the orbit, zygomatic bone, and the frontal bone as well. Moving to Lyphoid fracture. Lyphoid fracture is also called as pyramidal fracture. The fracture line starts just below the frontonasal suture. It fractures the frontal process of the maxilla. At first, it fractures the nasal bone, then it fractures the frontal process of the maxilla. Then it fractures the medial wall of the orbit. It fractures the infraorbital rim or orbital floor. It comes out of the orbital rim at the inferior orbital margin. It may or may not involve the infraorbital foramen. If it does not involve the infraorbital foramen, the fracture line exits medial to the infraorbital foramen, fractures the anterolateral wall of the maxillary sinus just below the zygomatic buttress. Then it crosses the pterygomaxillary fissure and fractures the pterygoid plate at the junction of upper half and lower half. So as shown in figure, it is not ideal Lyphoid fracture because clinically in practical scenario you could not find the accurate Lyphoid fracture which was given by Rennie Lyphoid. Okay, so ideally the Lyphoid fracture should pass or should start from the just below the frontonasal suture. It should fracture the nasal bone, then it should fracture the frontal process of the maxilla, then medial wall of the orbit. The medial wall of the orbit consists of lacrimal bone, then it fractures the orbital floor. It comes out of the orbit through the infraorbital margin. It may or may not involve the infraorbital foramen. If it does not involve the infraorbital foramen, then the fracture line passes medial to the infraorbital foramen. The fracture passes below the zygomatic buttress, passes posteriorly. It crosses the pterygomaxillary fissure. The pterygomaxillary fissure is present between the pterygoid plates and the posterior wall of the maxilla, and it also fractures the pterygoid plate. It is present posterior to the maxilla, and it fractures the pterygoid plate at the junction of upper half and lower half. Okay. So in this scenario, clinically, there is floating of maxilla. Occlusion will be deranged. There will be periorbital ecchymosis, epistaxis. This is the ideal Lyphoid fracture. The fracture line has started just below the frontonasal sutures. It fractures the nasal bone, then it fractures the frontal process of the maxilla, then it fractures the medial wall of the orbit. In the medial wall of the orbit, it fractures the lacrimal bone just posterior to the lacrimal sac. Then it comes out of the orbit through the infraorbital foramen. It may or may not involve the infraorbital foramen. If it does not involve the infraorbital foramen, then the fracture line exits to the medial to the infraorbital foramen. Then it fractures the anterolateral wall of the maxillary sinus just below the zygomatic buttress. Then the fracture line passes posteriorly. It crosses the pterygomaxillary fissure and fractures the pterygoid plate at the junction of upper half and lower half. So here the Lyphoid fracture shows the dislocation and occlusal disturbance. There is high and low variation as it crosses the nasal bridge, high at the frontal bone, and low variation just under the nasal bone. So ideally, the fracture line should start just below the frontonasal sutures in the nasal bone, but there are some variations in the upper variation, high variation. The fracture lines passes either at the junction of frontonasal suture or Above the frontal nasal suture, it fractures the frontal. In the low variation, the fracture line passes just below the ideal line, ideal L4-2 fracture, and it may or may not fracture the nasal bone. It may fracture the nasal cartilage. It is also known as pyramidal fracture due to its shape. Next is L4-3 fracture. L4-3 fracture is also known as craniofacial disjunction. In L4-3 fractures, ideally the fracture line starts at the frontonasal sutures. It disarticulates the frontonasal sutures, then also it disarticulates the suture between the frontal process of the maxilla and the frontal bone. Then it fractures the medial wall of the orbit. In the medial wall, it fractures the lacrimal bone. Then lamina papyracea of the ethmoid bone, which is present on the medial wall of the orbit. In the posteriorly, it never involves the optic foramen because the optic foramen is made up of thick bone. So here the fracture line divided into two parts. One fracture line fractures the lateral wall of the orbit, and it fractures the zygomatico-frontal sutures as well as it fractures the zygomatic arch. Another fracture line passes below and fractures the posterior wall of the maxillary sinus, and again it crosses the pterygomaxillary fissure and fractures the pterygoid plate at the junction of upper 1/3 and lower 2/3. And this fracture is also known as craniofacial disjunction because the facial bone completely separates from the cranium. Okay. In all the L4, 1, 2, and 3 fractures, there will be floating maxilla. Occlusion will be deranged. It shows the L4-3 fractures. So typical dislocation and occlusal disturbances. The fracture line, it is again there are variations. Ideally, the fracture line should passes through this frontonasal sutures, but there are some variations. Practically, you will never find the ideal L4 to 1, 2, or 3 fractures as given by Rennie report. So the fracture line has fractured the nasal bone as well as frontal process of the maxilla, then the medial wall of the orbit, where it fractures the lacrimal bone, then lamina papyracea of the ethmoid bone. Posteriorly, it never involves the optic foramen. Near the optic foramen, the fracture lines divide into two parts. Laterally, the fracture line fractures the lateral wall of the orbit. It may involve the sphenoid bone. It fractures the zygomatico-frontal suture, and also it fractures the zygomatic arch. On the fracture lines go downward and fractures the posterior wall of the orbit and it crosses the pterygomaxillary fissure and fractures the pterygoid plate. The pterygoid plate is present posteriorly, just posterior to the maxillary sinus, and fractures the pterygoid plate at the junction of upper 1/3 and lower 2/3. Clinical features are there will be deranged occlusion, there will be epistaxis, nasal bleeding, swelling in the midface, there may be emphysema. Emphysema is the collection of air within the tissue. There will be periorbital ecchymosis, subconjunctival hemorrhage, increased intercanthal distance. These are the features of L4-3 fracture. As you can see, the CT scan of axial view in the first figure of L4-2 fracture shows the fracture line through the anterior and posterior maxillary sinus wall. CT scan of axial view in the second figure, it is of L4-2 fracture, so the fracture line through both the infraorbital rings and the zygomatic arch on the right. Again, in third figure, there is CT scan of coronal section. So the fracture at L4-3 level on the right and the L4-2 level bilaterally. CT scan of 3D reconstruction of panfacial fracture. So these are the CT scan of L4 fracture. And in most of the cases, practically you will find the combination of fracture, L4-1 fracture, L4-2 fracture, L4-3 fracture, along with the other bone fracture. And most of the time in the midface, there are presence of thin bones, so there will be comminuted fracture. Unlike in mandible fracture, you will never find the simple fracture. So most of the time there will be comminuted fracture. In the first figure, as you can see, there is discontinuation present in the right side of anterolateral wall of the maxillary sinus, as well as the discontinuation present in the posterior lateral wall of the maxillary sinus. Okay. Similarly, on left side also, the anterior lateral wall is fractured at two points. Also, there is discontinuation in the posterior lateral wall of the maxillary sinus. Again, in the second figure, you can see there is discontinuation of the bone. This is the fractured part of the anterior lateral wall of the maxillary sinus. In the coronal section, as you can see, the lateral wall of the orbit is also fractured. There is fracture of the zygomatico-frontal suture. There is discontinuation, and the zygomatic bone is displaced laterally. Okay. Also at leaf 41 level, you can see the discontinuation present in the anterolateral wall of the maxillary sinus. There is discontinuation present in the anterolateral wall of the maxillary sinus. It is fractured at 2 points. One is in this region in the anterolateral wall of the maxillary sinus, another just below the zygomatic bone. On the right side, on the left side also, you can see the discontinuation present in the zygomatic buttress. Zygomatic maxillary buttress is gone. There is fracture is present at the two places at 2 points. There is discontinuation. Also, if you see the orbital floor or nasal wall, the medial either the lateral nasal wall or the medial nasal wall, all of them are fractured and there is comminuted fracture. Okay. So this is a 3D reconstruction of panfacial fracture. As you can see, the mandible is also fractured, midface is also fractured. In the midface, there is zygomatic bone is fractured and it is displaced laterally. The nasal bone is also fractured. Infraorbital rim is also gone. So what is this structure? This long structure. Here the patient is intubated. It is endotracheal tube. Okay. So don't be confused. So the panfacial fracture is if the face is divided into three parts: lower third, middle third, and upper third. Among them, if the midface is fractured along with either lower 1/3 or upper 1/3, then it is known as panfacial fracture. So here the midface is fractured as well as the mandible is fractured. There is left parasympathetic fracture as well as condyle is also fractured. So it is a case of panfacial fracture. In this case, we have to operate both the mandible as well as midface. And in the midface, due to presence of thin bone, we have to use 1.5 mm mini plates. Now, for approaches in case of midface fracture, how will you approach the fracture? So there is something called bicoronal approach. In case of bicoronal approach, we have to start the incision from the preauricular area. We have to extend the preauricular incision just above the frontal bone. We have to give the incision all over the head and we have to extend it to the contralateral side of preauricular incision. Or you can extend the incision posteriorly in the postauricular area. Okay. There are different variations. You can give either a straight incision and you can give, or we can give the incision in the zigzag pattern, or you can give the incision in the wavy pattern. The purpose of the giving either a straight incision or this zigzag incision or wavy incision, their modification is when you give the incision, the problem is in the postoperative case, in the area of the incision line, the hair follicle which are present in that area will be damaged. Okay, so there will be on-site scar in the head. So in order to avoid the straight scar line, we can modify the incision either in the zigzag pattern or wavy pattern so that the scar mark will be hidden within the hairline. Okay. In the scalp, there are 5 layers. The superficial, the uppermost is skin, then followed by connective tissue, then aponeurosis, gallia aponeurotica, then loose irregular tissue, and then followed by pericranium. While giving the bicoronal incision or coronal incision, we have to raise the flap in the layer of loose irregular tissue. So the part of the skin, then aponeurosis or aponeurotica are present superiorly and pericranium is present inferiorly. We have to split this flap in the loose irregular tissue. Scalp को layer of SCALP, S stand for layer of skin, then C for connective tissue, the A stand for aponeurosis, it is also known as gallia aponeurotica, then followed by fourth layer is loose irregular tissue and the last layer is pericranium. We have to raise the flap through loose irregular tissue because we can't split the layer between the skin, connective tissue or gallia aponeurotica. So the skin, subcutaneous connective tissue, and gallia aponeurotica is present superiorly, and below the loose irregular tissue there will be pericranium. We have to split the flap, or you have to raise the flap through the loose irregular tissue. In the upper 3 layers, S stands for skin, C stands for connective tissue, then SCA stands for aponeurosis. It is also known as gallia aponeurotica. Then L stands for loose alveolar tissue. And the last one is P stands for pericranium. It is a short form of layer of scalp. S for skin, C for concave tissue, A for aponeurosis, L for loose alveolar tissue, P for pericranium. The layer which is present superficially, the skin, subcutaneous concave tissue, and aponeurosis or gallia aponeurotica are firmly adhered to each other, so we can't split between them. So the only option left is we have to raise the flap through the loose alveolar tissue. You can only raise the flap through the loose alveolar tissue. Pericranium is present inferiorly and our other three layers are present superiorly. After raising the flap, you can expose the supraorbital rim, zygomatico-frontal suture, zygomatic bone, frontonasal suture, again the contralateral supraorbital rim, and of course, if there is any frontal bone fracture, you can reduce it, as well as you can expose the frontal sinuses. If the fracture is present in this area, you can raise the bicoronal flap, or you can give the bicoronal incision. It is the big incision. If there is comminuted fracture, if there are multiple fracture, if it is a case of case of panfacial fracture, if the frontal bone is fractured, then you can give the bicoronal incision. And you can expose all the bone which is present in the upper midface. So its limitation is you can extend only up to nasal bone, the upper part of nasal bone, the upper part of zygomatico bone. You can't reach up to the zygomatico-frontal suture, zygomatico-maxillary suture. Okay, because due to the presence of globe of the eye, you can't go below this. You can't extend the flap beyond this line. You may damage the eyeball. The structure which is shown in this circle by the arrow is it is neurovascular bundle which is present in the supraorbital rim. So we have to release it. Okay. Now, fracture of pterygoid plates. The pterygoid plate is fractured at different levels. In case of Lyford 1, 2 and 3, in the Lyford 1, it fractures at the junction of upper 2/3 and lower 1/3. In Lyford 2 fracture, it fractures at the junction of upper half and lower half. And in case of Lyford 3 fracture, the pterygoid plate fracture at the junction of upper 1/3 and lower 2/3. We have to remember this because the pterygoid plates is fractured in all Lyford 1 and 2 and 3 fractures, but it fractures at different level. In case of Lyford 1 fracture, it is at the lower level. In Lyford 2 fracture, it is in the middle region. In Lyford 3 fracture, it fractures at the upper level. So Lyford 1 level, it fractures at the junction of lower 1/3 and upper 2/3. In the Lyford 2 fracture, it fractures at the junction of upper half and lower half. In Lyford 3 fractures, it fractures at the junction of upper 1/3 and lower 2/3. So this is the Lyford 2 fracture with mini plate osteosynthesis. The infraorbital rim and naso-orbital lithoid area are stabilized with mini plates. Zygomatic maxillary buttress are stabilized with mini plates, and mandibular maxillary fixation is maintained during surgery only. As you can see, in case of Lyford 2 fractures, we have to fix the fracture line only in the area of buttresses. You can't place the mini plates and screw where the bone is thin. So you have to always put the plate in the buttress area. The buttress area in the midface are zygomatic maxillary buttress, nasomaxillary buttress, infraorbital rim, or the lateral wall of the or in the region of this frontal process of the maxilla or the lateral wall of the nasal cavity. Okay. So in case of midface fracture, in case of Lyford 2 fracture, we have to put the 1.2 or 1.5 mini plate in the frontal process of the maxilla. On the plate at the infraorbital rim, the third plate at the zygomatic maxillary buttress. You can't put the plate in any other area because in this area it is the anterolateral wall of the maxillary sinus. In this area the bone is thin. You can't put any plate or screw in here. Okay. And most importantly, whenever you are treating either midface fracture or mandibular fracture, if the occlusion is involved, you have to do mandibular maxillary fixation intraoperatively. The first thing is function. You have to maintain the occlusion. First, you have to put all the teeth in the occlusion. Once the occlusion is stabilized, then only you have to fix the fracture. Whether it is mandibular fracture or midface fracture, occlusion in most, you have to maintain the occlusion. Intraoperatively, you have to put the teeth in mandibular maxillary. You have to do the mandibular maxillary fixation. Once the mandibular maxillary fixation is done, Then you can put a plate and screw. After fixation of the fracture fragments, then again you can release the mandibular maxillary fixation. The IMF or MMF is done only intraoperatively. It's neither present preoperatively nor postoperatively, but you have to maintain the occlusion during the surgery. Again, fixation of leaf foot 1, 2, and 3 fractures with mini plate 2 and 1.3 on the left. A bone graft is covering a bony defect at the zygomatic-maxillary buttress area. So it is a case of panfacial fracture. Multiple bone is fractured here. Okay, and clinically, in case of high energy trauma, you will find sorts of panfacial fracture. All the mid faces comminuted fracture. So you have to join all the fracture fragments. And most important thing is you have to put the plate in the always in the buttress area, the zygomatic-maxillary buttress area, nasomaxillary buttress area, infraorbital rim, zygomatic arch, zygomatic-frontal suture area, as well as frontal process of the maxilla. And if the bone loss is there, you have to put the graft as well. The structure shown here, it is a bone graft. If the bone defect is there, if the bone loss is present, then you have to replace it with bone graft. Bone graft can be taken commonly from, it is preferred from the anterior iliac crest. Other options are, you can take it from the posterior iliac crest as well as cranium or ramal bone or sometimes some symphysis or ribs, but commonly we take the bone graft from the anterior iliac crest, because you can take both the corticocancellous bone as well as cancellous bone or spongy bone. In the volume of the bone you can take is the for corticocancellous bone you can take up to the 4 centimeter up to 5 centimeter. In case of spongy bone or cancellous bone, you can take up to 50 cc. It is also preferred during alveolar bone grafting in case of cleft lip and palate cases. So you must remember, while placing a plate at the nasomaxillary buttress or zygomatic-maxillary buttress, you have to put a L-shaped plate. You can't put a straight plate, because if you put a straight plate, it will enter into the dental structure. You may damage the root of the tooth. And all the plates are of 1.5 mm system, and the length of the screw is 1.5 by 6 mm. Reconstruction plate is never placed in mid face. It is only for mandible. In all the thin area, you have to put a 1.5 mm system in case of zygomatic arch. As the zygomatic arch is thick, you can use 2 mm plate in case of zygomatic arch. Next is zygomatic-maxillary complex fracture, or it is also known as orbito-zygomatic-maxillary fracture, or it is also known as zygomatic-maxillary orbital fracture. ZMC fracture is an old term. Zygomatic-maxillary complex fracture, it is also known as orbito-zygomatic-maxillary fracture, or the more accurate term will be zygomatic-maxillary orbital fracture, because always the zygomatic bone always involves the orbit. So it's better to say zygomatic-maxillary orbital fracture. All these are synonyms. So if you see the zygomatic bone, it articulates with 4 bone and it has 5 sutures, because in the maxilla it articulates at 2 different places, one at the infraorbital rim and another at the zygomatic-maxillary buttresses. Okay. Here, as you can see, the frontal process articulates with the frontal bone. The temporal process articulates with the temporal bone. Here in the maxilla, it articulates at different places, one at the infraorbital rim as well as another at the zygomatic-maxillary buttresses. As well as, you must remember that the zygomatic bone also articulates with the sphenoid bone. This is the sphenoid bone. So it forms zygomatico-sphenoid suture, zygomatico-frontal suture, zygomatico-maxillary suture, as well as zygomatico-temporal sutures. The disarticulated zygoma has 4 processes. The frontal process, this is the frontal process, the temporal process, the posterior one is temporal processes. This is the frontal process. This is temporal process. One is orbital process. This one is orbital process. And the maxillary process. This is the maxillary process. So it consists of 4 processes. Previously, it was considered tripodal fracture because the sphenoid bone was not considered. Now it is called as tetrapodal fracture because it articulates with 4 different bones: the maxillary bone, frontal bone, temporal bone, as well as sphenoid bone. That's why it is also known as tetrapodal fracture. Previously, at the sphenoid bone is present within the orbit, inside the orbit, it was not considered. So it was termed as tripodal fracture. Now the term is changed and it is known as tetrapodal fracture because it articulates with 4 different bones. In the second figure, lateral is called demonstrating its articulation in the temporal bone, frontal bone, and maxillary bones. With the temporal bone, it articulates with the temporal bone and forms the zygomatic arch. From the zygomatic arch, there is origin of masseter muscle. Superiorly, the zygomatic bone articulates with the frontal bone. It forms the zygomatic of frontal suture, or it is also known as frontozygomatic sutures. Medially, it articulates with the maxillary bone and it forms the zygomatic maxillary buttress, as well as it forms the infraorbital rim. Okay. The last one, the frontal, is called demonstrating its articulation with the maxillary, frontal, and sphenoid bones. It is the frontal view. Here also it articulates with the frontal bone, the maxillary bone. The temporal bone is not visible here. And the most important thing, the zygomatic bone also articulates with the sphenoid bone. Sphenoid bone is present on the lateral wall of the orbit. So the zygomatic bone also articulates with the sphenoid bone. It forms the sphenozygomatic suture. And the most important significance of this sphenozygomatic suture is, in most of the cases, in high energy trauma also, as the sphenozygomatic suture is present within the orbit, inside the orbit, this suture, in most of the cases, it is not fractured or it is not displaced. Okay, so while treating the ZMC fracture, our clue whether the bone is reduced or not, we have to look for sphenozygomatic suture. If the sphenozygomatic suture is reduced, then it confirms that the zygomatic bone is in its original position. Because if you see the outside area, frontozygomatic suture or zygomatic maxillary suture, infraorbital rim or zygomatic arch, most of the time they are fractured. So intraoperatively or during the surgery, only clue left is for sphenozygomatic suture. You have to look at the sphenozygomatic suture. If the bone is reduced at the level of sphenozygomatic suture, then it confirms that the zygomatic bone is in its original position. In most of the fracture, the sphenozygomatic suture is not fractured because it is present in the deeper level. It is present within the orbit, on the lateral wall of the orbit. So this bone is not fractured most of the time. This suture is not disarticulated. So zygomatic bone separated from the craniofacial skeleton. It has 5 articulation. Though it articulates with 4 bones, there are 5 articulation. In the maxilla, it articulates at 2 different positions. One at the zygomatic frontal, one at the zygomatic maxillary sutures, another at the infraorbital rim. With all other bone, it forms articulation at only 1 places, but in case of maxilla, it forms the articulation at 2 places. Okay, that's why it has 5 articulation. The one is, it articulates with the frontal process or frontal bone and it forms the zygomatic frontal suture. The structure 2, it forms the zygomatic maxillary buttress because the zygomatic bone articulates with the maxilla and forms the zygomatic maxillary buttress. The third one, again, the zygomatic bone articulates with the maxillary bone and it forms the infraorbital rim. The 4 is zygomatic arch. The zygomatic bone articulates with the temporal bone and it forms the zygomatic-temporal suture, and it forms the zygomatic arch where the masseter muscle is attached in this area, as well as there is attachment of temporalis fascia. Temporalis fascia is present superiorly, masseter muscle is present inferiorly. Okay, that's why whenever there is only isolated zygomatic arch fracture, in such cases, you don't have to reduce or fix. You don't have to fix it because in case of depressed fracture of the zygomatic arch, once you elevate the zygomatic arch, okay, it will be stabilized. because it is attached with the masseter muscle, which is inserts at the lateral wall, at the lateral surface of the ramus and angle, and also there is attachment of the temporalis fascia superiorly, which arises from the temporal bone. So due to attachment of temporalis fascia superiorly and masseter muscle inferiorly, you don't have to fix it. If it is simple fracture, if it is depressed fracture, just you have to elevate the zygoma through the buccal sulcus approach of the or the temporal approach. Once you elevate the zygomatic arch, it will be stabilized itself with the help of masseter muscle and temporalis fascia. It has 5 articulations. It articulates with the forebone. It articulates with the forebone, so it is also known as tetrapodal fracture. It has 5 articulations. In the maxilla, it forms 2 articulations. One articulation forms the zygomatic-maxillary buttress. Another articulation forms the infraorbital rim. A common pattern of injury in case of ZMC fracture. So, in case of ZMC fracture, it varies from very simple fracture on displaced fracture to there may be comminuted fracture. All 5 processes may have disrupted. So in first figure, as you can see, the ZMC is fracture, but it is undisplaced or minimally displaced. All the bones are adjacent to each other. Though it is fracture, but it is undisplaced. You have to compare with the contralateral side. ZMC is fracture, but it is undisplaced or it is minimally displaced. Okay, in second figure also, it is undisplaced fracture of the right ZMC. Okay. Sometimes what happens, there will be depressed zygomatic arch fracture. It is very common fracture. You will find many cases clinically. In case of depressed zygomatic arch fracture, zygomatic arch may be fractured at different places, and in such cases, what happens? There is presence of temporalis bone, temporalis muscle just below the zygomatic arch, so it impedes over the temporalis muscle, and there will be reduced mouth opening. There will be trismus. The structure which is present just below the zygomatic arch is coronate process and temporalis muscle. So whenever there is depressed zygomatic arch fracture, it impedes over the temporalis muscle, and it will lead to a spasm of the temporalis muscle, and the mouth opening will be reduced. There will be trismus. Okay, this is also a case of depressed zygomatic arch fracture where there is comminuted fracture, all the bone are fractured, and it has impinged over the temporalis muscle. Okay. So another pattern of injury can be zygomatic arch may have been fractured and it has been pulled outward. In this case, clinically, you can see there will be facial asymmetry. There will be balls present in the zygomatic arch area. Now, what will be the clinical features of ZMC fracture? In case of depressed zygomatic arch, due to impinging over the temporalis muscle and or coronate process, there will be limited mandibular exertion. The mouth opening will be reduced. That is one of the clinical features in case of ZMC fracture. So one feature is there will be trismus, reduced mouth opening in case of ZMC fracture. Whenever there is depressed zygomatic arch fracture, it will impinge over the coronate process and temporalis muscle, so it will lead to trismus due to a spasm of temporalis muscle. The second clinical feature can be fracture may extend along or through the infraorbital groove or canal along the orbital floor and frequently crosses the infraorbital foramen on the facial surface of the maxilla. Infraorbital nerve is a branch of which nerve?
Maxillary nerve.
It's the branch of maxillary division. As it exits from the infraorbital foramen, it gives 3 branches. One is lateral nasal, another is inferior palpebral, another is superior labial. Superior labial branch supplies to the lips. Lateral nasal branch supplies to the lateral wall of the nose, and the inferior palpebral supplies to the palpebrae of the eye, lower palpebral fissure. So there will be numbness over this area. Whenever you give the infraorbital nerve, there is also doesn't feel numbness over the lip, lateral wall of the nose, as well as lower eyelid. It is due to because you are anesthetizing the infraorbital terminal branches of infraorbital nerve as well. infravital block दिँदाखेरि local anesthesia कहाँ डिपोजिट गरिन्छ? Giving the infravital nerve block, you deposit the local anesthesia in the region of infravital foramen, so that the local anesthesia will diffuse and enters into the infravital foramen. It will anesthetize the anterior superior nerve and middle superior nerve. So whenever you deposit the local anesthesia in this area, infravital foramen, along with the anterior superior nerve and middle superior nerve, these terminal branches will also get anesthetized. These terminal branches are superior labial branches, lateral nasal branches, and inferior palpebral branches. So patient will feel numbness over the lip, lateral wall of the nose, and lower eyelid. Okay. So in case of ZMC fracture, as you know, this infravital foramen is present within the fracture line. So whenever ZMC is fractured and if the infravital nerve is traumatized, it will lead to paresthesia of these terminal branches. The patient will have numbness over the lip, lateral wall of the nose, and lower eyelid. So one of the clinical features of ZMC fracture is numbness over the terminal branches of infravital nerve. And most of the time, if the infravital foramen is involved in the fracture, then it will lead to trauma to the infravital nerve. So infravital nerve will not function. It will lead to paresthesia of these area: upper lip, lateral wall of the nose, and lower eyelid. Another feature is inferior displacement of the zygoma results in depression of the lateral canthus and pupil because of depression of the suspensory ligaments that attach to the lateral orbital wall, or which is also known as Whitnell's tubercle. If you see the structural anatomy of the eye or globe, there is some structure called as the bony prominence, which is known as Whitnell's tubercle. So the suspensory ligament is present from this Whitnell's tubercle to the medial wall of the orbit. So whenever there is ZMC is fractured, this structure will come down along with the suspensory ligament, which is present in the Whitnell's. There is the bony prominence, which is present in this area, is known as Whitnell's tubercle. Okay, the Whitnell's tubercle. In the Whitnell's tubercle, there is attachment of suspensory ligament of the eye globe. This suspensory ligament holds the eyeball. Whenever the ZMC is fractured, and if this ZMC zygomatic bone comes down, then what will happen? Along with this bone, the Whitnell's tubercle, which is present at the lateral wall of the orbit or within the zygomatic bone, will also come down. So it will lead to, along with this, the suspensory ligament will fall down. So the position of the globe will be changed. The eyeball will come down. So position of the eyeball will be changed, and it is known as hypoglobus. There will be inferior displacement of the globe of the eye. If both the eye are not at the same level, if the level of the eye is changed, if it is displaced downward, then this condition is known as hypoglobus. So in case of ZMC fracture, there may be presence of hypoglobus. Hypoglobus means the level of the eyeball is displaced inferiorly. Inferior displacement of the zygoma results in depression of the lateral canthus and pupil because of depression of suspensory ligament that attach to the lateral orbit, which is also known as Whitnell's tubercle. So in normal condition, what happens? The zygomatic bone is attached to the frontal bone. There is bony prominence on the lateral wall, which is known as the Whitnell's tubercle. So suspensory ligament attached from with this Whitnell's tubercle to the medial wall of the orbit. It holds the whole of the globe of the eye. So whenever this ZMC is fractured, the bone will be displaced downward. Along with this bone, the Whitnell tubercle will also displace downward. So it will lead to the suspensory ligament along with the globe will fall down. It will be displaced inferiorly, and this condition is known as hypoglobus. Hypo means low, globe means eyeball. So there is inferior displacement of the eyeball. Clinically, we have to compare the position of the contralateral side. Position of the normal side, we have to compare with the position of the globe on the fractured side, the traumatized side. If the position of the eyeball or position of the pupil is not at the same level, if the eyeball is present displaced more inferiorly, this condition is known as hypoglobus. So now the next feature is, in case of ZMC fracture, you may find hypoglobus. Next clinical feature can be subconjunctival hemorrhage. Subconjunctival hemorrhage means the blood accumulates within the conjunctiva. As you can see, the blood is accumulated within the conjunctiva, outside the sclera, which is present just below the conjunctiva and outside the sclera. So the whole of the eye will appear as a bright red color. These are also one of the feature of ZMC fracture. And remember that the subconjunctival hemorrhage is not only present in the ZMC fracture; it may be present in any fracture which have involved the orbital rim or orbital wall. It may be associated with NOE fracture, naso-orbital ethmoid fracture, or nasal bone fracture, or frontal bone fracture, infraorbital rim fracture. Any structure which is present around the eye may lead to subconjunctival hemorrhage. Now the question is, why the subconjunctival hemorrhage is not present in front of pupil or cornea? Why there is limitation within the, why it has not crossed this scleral line? As you can see, there is clear-cut margin between the cornea and iris and the sclera. The blood has not entered to the iris. Because in this area, the conjunctiva is firmly adhered with the margin of the iris. So blood which is accumulated around the iris, which is present in front of the sclera, could not cross the iris line, because in this area, the cornea is firmly adhered to the iris, so that the blood could not enter into the pupillary area or corneal area. So subconjunctival hemorrhage is present just in front of the sclera. It will not enter into the cornea. If it enters into the cornea or lens, it is a different condition. Sometimes it may rupture due to trauma. It may have been ruptured, maybe have been traumatized. It may rupture. In that condition, blood may enter into the eyeball. That is a different condition. Okay. Another question is, in case of subconjunctival hemorrhage, the blood appears bright red. Why? In case of subconjunctival hemorrhage, the blood which is accumulated within the conjunctiva in front of a sclera, just adjacent to the sclera, it appears more bright. What is the reason behind it? Because the conjunctiva is permeable to oxygen. So the blood which is present in the subconjunctival hemorrhage is more oxygenated as compared to other blood in the blood or other blood in the body. That's why, as compared to the normal blood in the body, subconjunctival hemorrhage appears more bright because it is more oxygenated. Conjunctiva is permeable to oxygen. That's why these bloods are more oxygenated. So it appears, subconjunctival hemorrhage blood appears more bright. It is more bright red in color. Another thing you must be knowing, cornea do not have any blood supply, as well as lens do not have any blood supply. It gets oxygen directly from the air, from the atmosphere. Because the conjunctiva is permeable to oxygen, it directly gets the oxygen from environment through the conjunctiva. That's why during eye donation, most of the time either cornea or lens is donated, because it does not consist of any tissue, any blood, so it can be donated to other persons. Another feature is periorbital ecchymosis. In case of ZMC fracture, periorbital ecchymosis is presence or accumulation of blood within the periorbital region. The accumulation of blood within the periorbital tissue, soft tissue, is known as periorbital ecchymosis. Again, such periorbital ecchymosis is present more commonly in the old age patient, because in case of old age or geriatric patient, the loose conduit tissue which is present within the around the orbit or periorbital tissue are loose, so it can hold more amount of blood. Another thing, why the blood accumulates only within the in the periorbital area is the subcutaneous tissue which is present in the area of periorbital region is more loose. They are not firmly adhered. That's why the blood can easily accumulate in the periorbital region. You can't find such a periorbital, such ecchymosis in the other area like nose or cheek or forehead. It is only present in the periorbital region because in the periorbital region, the loose the conjunctive tissue which is present within this periorbital region is loose, and so it can hold more amount of blood and it will lead to periorbital ecchymosis. As compared to a young patient, the geriatric patient will have the chances of periorbital ecchymosis is more in case of geriatric patient as compared to young patient. Because in case of geriatric patient, the connective tissue which has connective tissue fibers which are present are more loosely arranged, so it can hold more amount of blood. That's why it will lead to commonly to lead to periorbital ecchymosis in geriatric patient. Next feature is periorbital edema. Periorbital edema is accumulation of tissue fluid in the periorbital region. It also may be present in case of ZMC fracture. If the zygomatic bone is traumatized, but if there is no bleeding around the periorbital tissue, so the tissue fluid will be accumulated in the periorbital region and it is known as periorbital edema. There is no blood. If blood is present, then it is known as periorbital ecchymosis. If blood is not present, if only the tissue fluid is present, then it is known as periorbital edema. Now, the skeletal deformities in case of ZMC fracture is there is asymmetry of the midface, okay, depression or flattening of the malar prominence, flattening or hollowing or bony indentation or broadening over the zygomatic arch, palpable step of or gap deformities of orbital margins in the infraorbital or lateral region. If the ZMC fracture, there is skeletal deformities as well. Commonly, you can see the facial asymmetry. Either there is depression of the zygomatic bone or there is flattening of the malar prominence. And if you palpate the infraorbital rim or zygomatic frontal suture, you can find the step deformity. There are many ocular or ophthalmic symptoms like periorbital edema or hematoma, pseudotosis, increased scleral soot, downward slant of palpebral fissure or horizontal lead axis respectively, due to downward displacement of the Whitnell's tubercle, malposition of the lateral canthus, vertical shortening of the lower eyelid. It is also known as ectropion. Subconjunctival ecchymosis, mostly either in temporal region or medial region. There may be chemosis. Chemosis is accumulation of fluid within the conjunctiva. Edema of the conjunctiva is known as chemosis. Pupillary or globe level disparity is known as hypoglobus, where the globe of the eye is present or displaced inferiorly. There may be proptosis bulbi, inophthalmos, outward displacement of zygoma. Due to outward displacement of the zygoma, the eyeball will be displaced posteriorly, inwardly, and this condition is known as inophthalmos. If the eyeball is displaced inwardly, posteriorly, then it is known as inophthalmos. In contrast, if the eyeball is displaced anteriorly, then it is known as exophthalmos. If the eyeball is present or displaced anterior to its normal position, it is known as exophthalmos. If the eyeball is displaced posteriorly or inward, then it is known as inophthalmos. Inophthalmos may be present in the outward displacement of the zygoma. Just opposite, if there is depressed fragment of the zygomatic bone, in that condition, the orbital volume will be decreased. It will lead to outward bulging of the eyeball. It is known as exophthalmos. There may be subcutaneous periorbital air emphysema, pneumoexophthalmos, diplopia due to neurogenic ocular motility disorder of third, fourth, and sixth cranial nerve. There may be inophthalmos, entrapment, revolved by post-option test. Now, what is diplopia? Diplopia means the structure of eye shows that we have binocular visions. That is, both of our eye look at the same object simultaneously. But in case of diplopia, what happens if during a trauma, if some of the nerve is traumatized, either third, fourth, or sixth. So what is the significance of third, fourth, sixth nerve in case of diplopia? If you see the extraocular muscles are supplied by these third, fourth, and sixth nerve. Okay. There is a formula known as SO4 LR6 rest 3. That is superior oblique is supplied by fourth cranial nerve. LR6 means lateral rectus is supplied by sixth cranial nerve. In rest 3, other extraocular muscles are supplied by third cranial nerve. What are the extraocular muscles? There are 4 rectus muscles: superior rectus, inferior rectus, medial rectus, and lateral rectus muscle, and 2 oblique muscles: inferior oblique and superior oblique muscles. So among these 6 muscles, superior oblique muscle is supplied by fourth cranial nerve, lateral rectus is supplied by sixth cranial nerve, and all other muscles are supplied by third cranial nerve. Which is a third cranial nerve? Oculomotor nerve is a third cranial nerve. Then trochlear nerve is fourth cranial nerve. Abducent is sixth cranial nerve. These 3 cranial nerves supplies the extraocular muscles. So in case of ZMC fracture, if some of these nerves are traumatized, so it will lead to diplopia. Or what happens sometimes if the orbital floor is fractured, it is very common. If the orbital floor is fractured, it will lead to entrapment of inferior rectus muscles. Once the inferior rectus muscle is entrapped, the motility of the eye is gone. You can move your eye. So in that condition, what happens? Both the eye focuses at 2 different positions. So clinically, what the patient will complain, if you show them one object, they will see it as a 2 objects, because both the eye make its image in the retina at 2 different places. Okay, so if you show them one finger or one ball pen, they say it appears it as a 2, because both the eye make an image in the retina at 2 different places due to diplopia. Because the motility of the eyeball is not there, they can, for their binocular vision is gone. So both the eye focuses at different position, and both the eye makes an image in the retina at different places, and the same object, the single object, can be viewed as 2, and it is known as diplopia. Another clinical feature of ZMC fracture is amaurosis. Amaurosis means there is no vision due to damage to the optic nerve or optic canal. Or there may be presence of superior orbital fissure syndrome. Superior orbital fissure syndrome, there are many features. In this condition, what happens? The structure which passes through the superior orbital fissure get compressed or traumatized. So all the blood vessels, artery, vein, and nerve which are present in the superior orbital fissure get traumatized, and then it will lead to various symptoms like there is a proptosis of eye. In late condition, there may be the loss of vision as well. Sensory impairment or sensory deficit, that is hypoesthesia or anesthesia in the distribution of the following nerves, like infraorbital nerve, where the terminal branches supplies to the lower eyelid, upper lip, and ala and lateral side of the wall of the nose. As the infraorbital nerve exits through the infraorbital foramen, it gives 3 terminal branches. Superior labial branches supplies to the upper lip. So there will be paresthesia or anesthesia of the upper lip. On the branches supplies to the lateral wall of the nose, so it will lead to anesthesia or hypoesthesia of the ala or lateral wall of the nose. On the third branches supplies to the lower eyelid, so it will lead to paresthesia or anesthesia in the lower eyelid as well. On the nerve is zygomaticofacial nerve and zygomaticotemporal nerve. These are present in the malar eminence region. Again, it will lead to hypoesthesia or anesthesia in the region of the cheek. So zygomaticofacial nerve will lead to hypoesthesia or anesthesia in the malar eminence and cheek area. So similarly, zygomaticotemporal nerve will lead to anesthesia or hypoesthesia in the lower lateral orbital rim, anterior temporal, lateral, and frontal region. Within the oral cavity or inside the oral cavity, in case of ZMC fracture, you will find ecchymosis in the gingivo-buccal maxillary sulcus. If you see the buccal sulcus posteriorly in the maxilla, you can find the ecchymosis, because the zygomatico-maxillary buttress which are present in that area gets fractured, and it will lead to presence of collection of blood, that is known as hematoma or ecchymosis. So ecchymosis may be present intraorally within the vestibule of the maxilla posteriorly. Subjective occlusal disorder due to altered sensation of the maxillary premolars, molars, and gingiva. There is no objective malocclusion. In case of ZMC fracture, there is no malocclusion, but there will be loss of sensation due to damage to the maxillary division of the mandible, of maxillary division of the trigeminal nerve. Palpable contour disturbance will be present in the maxillary buttress area. If you palpate the buccal sulcus in the maxilla, you will find the step deformity due to fracture of zygomatic maxillary buttress. There will be restriction of mandibular opening, trismus or unclosing due to blockage of temporal muscle or coronary process, either by impacted zygomatic arch or retro-displaced zygoma. In case of ZMC fracture, there may be reduced mouth opening. The mandible movement will be restricted due to either impingement over the temporalis muscle or coronary process, or due to posterior displacement of the zygomatic bone. Nasal symptoms in nose, you can find ipsilateral epistaxis or ipsilateral hematocynicity due to, because the zygomatic bone is fractured, zygomatic bone is just present superolateral to the maxillary sinus. So whenever there is zygomatic bone fracture, it will lead to bleeding within the maxillary sinus. Once the blood is accumulated within the maxillary sinus, it will come out through the nasal cavity, because the meatus which is present in the lateral wall of the nasal cavity will communicate with maxillary sinus with the nasal cavity. So there will be epistaxis or nasal bleeding on the same side. If the fracture is present on the right side, then the bleeding will also, blood will also come out from the right nostril. In the CT scan, you will find the ipsilateral hematosinus. The maxillary sinus will be accumulated with the blood. You will find the blood level in the maxillary sinus. Now in clinical examination, you have to palpate the infraorbital rim. You will find the step deformity in the infraorbital rim, because as you know, the zygomatic bone articulates with the maxillary bone. It forms the infraorbital rim. So you will find the step deformity in the infraorbital rim. Method of assessing posterior displacement of the ZMC from behind the patient. The clinician should firmly depress the fingers into the edematous soft tissue while palpating along the infraorbital areas. You have to stand in behind the patient, and you have to palpate at the infraorbital rim. You have to palpate the zygomatic arch. It is also known as bird's eye view, because you are looking from superior surface. Sometimes we have to examine the patient from the position below the face, from the chest area. That is known as worm view. If you are examining the patient from posteriorly, from above the patient, is known as bird's eye view. If you are examining the patient from the level below the chin or below the chest, it is known as worm view. In case of ZMC fracture, we have to examine the case from the bird's eye view. You have to stand in back of the patient. You have to palpate the infraorbital rim. You have to palpate the malar prominence. You can find the asymmetry. The fracture site may be depressed most of the time. If you palpate the zygomatic bone or malar prominence on the fracture side, you will find that the zygomatic bone is displaced posteriorly. If you examine the patient looking in front of the patient, you can't identify, you can't distinguish if the discrepancy is minor. So you have to examine the patient from standing behind them. Eye movement by extraocular muscles. Okay, in case of eye, there are 6 extraocular muscles: lateral rectus, medial rectus, superior rectus, inferior rectus, and there are 4 rectus and 2 oblique muscles. There are some confusion in the inferior oblique and superior oblique. Even though the name is inferior oblique, but it moves the eye superiorly and medially. In case of superior oblique, even though the name is superior, but it moves the eyeball inferiorly and medially. On that is same, the lateral rectus moves the eye laterally, medial rectus moves the eye medially, superior rectus moves the eyeball superiorly, and inferior rectus moves the eye inferiorly. All the muscles works in coordination, so that in normal condition, both the eye looks at the same position and both same object, and both of them make the image at the same position in the retina, In case of trauma, if there is trauma to the extraocular muscles or any of the nerve is damaged, then it may lead to diplopia, because both the eye could not focus on the same object, and it will lead to formation of two different images of same object, and it will lead to diplopia. The one object can be viewed as two. Another thing is there is something called force reduction test. Force reduction test is used to identify whether there is any restriction of eye movement or not. The force reduction test determines whether there is physical impediment to ocular motility. It is done by grasping of the inferior rectus muscle. Okay. So most of the time what happens, as you know, the thinnest bone present in the orbit is either orbital floor or medial wall, especially the lower part of the medial wall. So most of the time, whenever there is a blunt trauma to the eyeball, it will lead to fracture of the orbital floor. If the orbital floor is fractured, it will lead to entrapment of the inferior rectus muscle, because inferior rectus muscle is present just adjacent to the orbital floor. So whenever there is entrapment of the inferior rectus muscle, the motility of the eye will not be there. So in that condition, we have to check whether the inferior rectus muscle is entrapped or not. It is done by, you have to move the lower eyelid downward, and you have to hold the inferior rectus muscle is present just below the sclera in this area. So you have to hold the inferior rectus muscle, and you have to move the eyeball manually, superiorly, inferiorly, as well as laterally. If you can move the eyeball easily, mostly if you can move the eyeball superiorly or laterally or medially, then it indicates that the inferior rectus muscle is not entrapped. If you could not move the eyeball by grasping the inferior rectus muscle, then it indicates that the inferior rectus muscle is entrapped. So this is known as force reduction test, and if you could not move the eyeball, then it is known as force reduction test is positive, or the inferior rectus muscle is entrapped. Then you have to operate. You have to release the inferior rectus muscle, and you have to do orbital floor reconstruction. I think they have asked, what is force reduction test? Force reduction test is used to identify or check the motility of the eyeball, and mostly it is used to check the entrapment of inferior rectus muscle. It can be done by holding the inferior rectus muscle and moving the eyeball in all the direction. If you can move the eyeball in all direction, it indicates that the force reduction test is negative and there is no entrapment of muscle. If you could not move the eyeball, then it indicates that the force reduction test is positive and the inferior rectus muscle is entrapped. In case of ZMC fracture, there is radiography where you have to do radiographic evaluation, and most of the time, in almost all the cases, you have to do CT scan, or it is also known as NCCT phase. Another important question is, there is something called submental vortex view or zygomatic arch. It is done for zygomatic arch fracture. It is also known as zygomatic jog handle view. Okay, it is only done for zygomatic arch fracture. If you suspect there is zygomatic arch fracture, then you can go for submental vortex view. It is a plain radiograph, and most of the time they have asked this question: which plain radiograph is preferred in case of zygomatic arch fracture? It is submental vortex view. It is also known as jog handle view. It is indicated if you suspect there is zygomatic arch fracture. Again, if you see the CT scan, it's horrible because bone are very thin. Unlike mandible, mandible is thick bone, so there is clear-cut fracture. But in midface, it's not like that. Most of the time, you'll find small pieces of bone. Most of the time, there will be comminuted fracture, and multiple bone is fractured simultaneously. Okay. If you see the first figure, it is a coronal section. In coronal section, always, whenever you find any difficulty in diagnosing whether this fracture is present or not, you have to compare with the contralateral side. Clear cut, you can see there is haziness in the maxillary sinus, but it is clear cut black color on left side. So it indicates that there is collection of blood. So there is hemosinus present on the right maxillary sinus. Another feature is, you can see the bone is fractured and it is displaced medially. The zygomatic arch is also fractured and displaced laterally. Also, it is fractured at the leaf 1 level at two places, one at this area, one at the discontinuity of the bone. देखिएको छ, is there any abnormality? The anterolateral wall of the maxillary sinus is fractured at two different places. Zygomatic buttress is also gone. Zygomatic bone is fractured and it is displaced laterally. If you see the lateral wall of the eyeball, it is also fractured. The medial wall of the maxillary sinus or lateral wall of the nasal cavity is also fractured. There is accumulation of blood as compared to contralateral side. There is clear cut. The sinus is filled with air, but in the ipsilateral side, you can see the haziness. It is due to accumulation of blood within the maxillary sinus. Okay, this is the coronal section. Always you have to see the fracture from all the sections. You have to see all the section: coronal section, sagittal section, axial section, and finally 3D reconstruction of VRT image. This is coronal section. If you see the axial section, you can see the lateral wall of the orbit is fractured. The bone is fractured and it is displaced. If you compare it from the contralateral side, from the left side, the bone is fine. There is no any fracture. But if you see the ipsilateral side on trauma side, you can see the bone is fractured and it is displaced. Okay, this is the lateral wall of the orbit. Again, the axial section at another position, you can see the zygomatic arch is bulged outwardly. The zygomatic arch is fractured and it is bulged outward. The anterior lateral wall of the maxillary sinus is fractured and it is displaced inwardly. Also, the posterolateral wall is also fractured. The maxillary sinus is fractured and there is comminuted fracture. Multiple pieces of bone are there. Okay. Again, the axial section at different view, you can see the anterior lateral wall of the maxillary sinus is fractured and depressed inward. You can compare with the contralateral side where the fracture, where there is no any fracture and it is a normal side. Okay, you can't find any discontinuity and the sinus is filled with air. On trauma side, you can see the anterior lateral wall is fractured, posterior lateral wall is also fractured. The fracture fragment is displaced. Okay. And this haziness is due to accumulation of blood, and this black color is due to presence of air. Now, in the same sinus, you can find there is accumulation of blood in this area, and there is air in superior area. Why? There is accumulation of blood in the posterior region, and there is air is present in the anterior region. Why? What is the reason? Because while taking the NCCT phase, while taking the CT scan, patient is in supine position. So in the supine position, what happens? All the blood which are present will be collected in the posterior region. So posteriorly there is accumulation of blood, but in the superior region there is presence of air. Always CT scan is taken in the supine position. So any fluid, any blood, any tissue fluid which is present will be accumulated due to gravity in the dependent position. So during supine position, these blots are accumulated posteriorly. That's why it appears as a haziness. In the more superiorly, there is presence of air. It appears as a black color. On the again, it is a case of zygomatic arch fracture. You can see the zygomatic arch is depressed fracture. Fracture is present at three different positions. The fracture is present here, here, as well as here. It is a depressed zygomatic arch fracture. So what will you suspect in this case? Clinically, what will you find? As there is a depressed zygomatic arch fracture, it will impinge over the coronary process as well as temporalis muscle. So it will lead to trismus. Another feature you can find is clinically you can see facial asymmetry. There will be depression of zygomatic arch. The malar prominence will be depressed. Okay. If you see the 3D, you can see the zygomatic arch fracture at three different locations. It is depressed zygomatic arch fracture. Again, another figure, axial section, you can see there is outward bulge of the zygomatic arch. So zygomatic arch is again fractured at three different places. In 3D reconstruction, you can see the zygomatic arch is fractured at four different locations. Here, 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 and here. If you see the radius, oh sorry, 5 position. Here also it is fractured. Okay. If you see the axial section, you can compare it with the contralateral side. The zygomatic arch is straight on the contralateral side, but it is bulged outward due to fracture. So in all these conditions, you have to operate the case. You have to operate the case, reduce the zygomatic fracture part, and you have to fix it with mini plate. And in case of zygomatic arch, you can use 2 mm plate. In other part of the midface, we have to use 1.5 mm system thin plate, because the bone which are present in the midface are all thin bone, so you can't use a thick plate. Again, you can see the right side of the zygomatic bone is fractured. There is flatness present over the malar prominence. The fracture is present in the zygomatic frontal suture as well as in the region of zygomatic arch, where it articulates with the temporal bone. Also, it is fractured in the infravertebral rim area. Okay. If you see this 3D, the zygomatic arch is fractured and it is bulged outward. In the coronal section, again, you can see that there is continuity present in the zygomatic frontal suture. Orbital floor is also fractured and orbital contents it is bulged out, because you can compare it with the contralateral side. Here the orbital floor is intact, but on right side the orbital floor is fractured and the orbital content is herniated into the maxillary sinus. Okay. Again, same thing, the zygomatic bone is fractured completely, orbital floor is also fractured, orbital content has been bulged into the extruded into the maxillary sinus. The maxillary sinus is also filled with blood. On left side, this is normal. So submental vortex view, or it is also known as jog handle view, it is preferred to identify the zygomatic arch fracture. So whenever you suspect a zygomatic arch fracture, you can advise submental vortex view, or it is also known as jog handle view. It is only a plain radiograph which is of some importance in case of ZMC fracture. Otherwise, you have to see the NCCT phase CT scan, because in plain radiograph, due to presence of many small bone comminuted fracture, you can't identify whether the fracture is present or not. Even though if it is present, you can't identify the severity of displacement, severity of injury. So you have to do CT scan. Now, in case of ZMC fracture, it is very difficult to treat, because the first thing is you have to identify whether to operate or not. Because the ZMC fracture may vary from undisplaced fracture, minimally displaced fracture to severe displacement. So you have to rule out whether you will plan for surgery or not. So for surgery is indicated only in these 4 conditions. If the facial asymmetry is present due to depressed zygomatic bone fracture, depressed malar prominence fracture, if there is due to any condition, if there is facial asymmetry, then you have to operate the case. Another reason is if there is reduced mouth opening, there is trismus. If the patient could not open the mouth, then again you have to operate the second condition. Third condition is eye sign. If there is some feature related to eye, like if there is diplopia, there is hypoglobus, if there is exophthalmos, if there is enophthalmos, if there are severe subconjunctival hemorrhage, then again you have to operate the case. The fourth one is unresolving paresthesia. Paresthesia will be present in the region of upper lip, lateral wall of the nose, and lower eyelid. If the paresthesia is present in this area, and another thing is if it persists for more than 3 weeks, then only you have to operate, because paresthesia may be present in all the conditions if the infravertebral foramen is involved. If the infravertebral foramen is involved, it will damage the infravertebral, traumatize the infravertebral nerve and its terminal branches. But in the initial condition, it may be due to the trauma to the nerve, but slowly it may heal. If it does not heal till 3 weeks, then it indicates that there is some impingement over the nerve and we have to release it. So in that condition, you have to operate the case. Hope they will not ask such a difficult question. What you should know, that if there is unresolving paresthesia, then you have to operate. You don't have to remember the word 3 weeks. Okay, so indication of ZMC fracture for surgery is only these 4: facial asymmetry. If there is facial asymmetry, then you have to operate. If there is reduced mouth opening, if there is any eye sign, or if there is unresolving paresthesia over the terminal branches of the infravertebral nerve. Now, treatment of ZMC fracture. In case of depressed zygomatic arch fracture, you can operate it through the either temporal approach, or there is something called as intraoral approach or buccal sulcus approach. Okay. It is also known as Gillis temporal approach. It is a famous approach, and it was asked many times. The Gillis temporal approach is used to elevate the depressed zygomatic bone fracture. The instrument should be placed between the temporalis muscle and the temporalis fascia. The row zygomatic elevator is inserted just deep to the depressed zygomatic arch and then outward force is applied. In case of Gillis temporal approach, incision is given in the temporal area. The instrument is inserted through the two terminal branches of the temporal artery, and you have to place your instrument between the temporalis muscle and the temporalis fascia. You have to reach. If you follow the temporalis muscle is inserted into the coronate process, which is present just below the zygomatic arch. So if you follow the temporalis muscle, you enter into the just below the zygomatic arch, so you can elevate the depressed zygomatic arch. And the other significance of this row zygomatic elevator is the length of this two arm is equal. So when you have inserted your instrument inside the zygomatic arch, you don't know what is the depth, how much depth have you penetrated. So you have to compare this another arm, because the length of both arm is same. So you get the clue how deep you have inserted your instrument. Once it is sufficiently deep, you have entered through the zygomatic arch, then you have to pull the zygomatic arch, and the reduced zygomatic arch will be, the depressed zygomatic arch fracture will be reduced. And the good thing is you don't have to put any plate or screw in such cases, because it can be stabilized with the help of masseter muscle and temporalis fascia. Because the zygomatic arch, there is attachment of masseter muscle at the inferior border and the lateral surface, and there is attachment of temporalis fascia on the superior surface of the zygomatic arch. So with the help of these two structures, these two anatomical structures, temporalis fascia and the masseter muscle, the zygomatic arch will be stabilized. If it is simple depressed fracture, not in all cases. If it is comminuted fracture, then you have to open and you have to place the 2 mm plate. It is known as Gillis temporal approach. The instrument uses row zygomatic elevator. On the keen buccal sulcus approach for elevation of the zygomatic arch. In case of temporal approach, there will be unsightly scar mark will be present on the temporal bone or temporal region. So another option can be, you can go through the transoral approach or intraoral approach. It is also known as keen buccal sulcus approach. It is used for elevation of the depressed zygomatic arch fracture. In this case also, you have to give the incision from the canine area to the posterior region, and you have to insert your instrument supraperiosteally, because if you insert your instrument below the periosteum, you will enter into the more deeper structure. You can't reach to the zygomatic arch. So supraperiosteal dissection is done. You have to insert the either you can use a row zygomatic elevator, or you can use any forceps. Even extraction forceps can be used. And once you have reached to the zygomatic arch, you have to pull the zygomatic arch. Once it is reduced, you will get the some. If you have reduced it sufficiently, you don't have to fix it. Just leave as it is. It will be healed by itself. Suitable elevator inserted on the temporal surface of the zygomatic body for elevation. Dental extraction forceps used in a manner similar to that for a row zygomatic elevator. If you don't have row zygomatic elevator, you can simply use any extraction forceps. Flat instrument used to reduce the depressed zygomatic arch. If it is simple depressed arch fracture, you can operate it by buccal sulcus approach or temporal approach, either Gillis temporal approach or King's buccal sulcus approach. It is only for simple depressed fracture. If it is comminuted fracture, then you have to open this. In this condition, this procedure is also known as non-surgical approach. Even though you have to give the incision, but it is considered non-surgical treatment, because you don't have to open the surgical side. You don't have to fix it with a plate and screw. That's why it is also known as non-surgical treatment or closed treatment for depressed zygomatic arch fracture. So closed treatment for depressed zygomatic arch fracture is either through the Gillis temporal approach or King's buccal sulcus approach. For approaches to treatment of ZMC fracture, there are different approaches. One, in case of bicoronal approach, it is a big incision, it is a big surgery. When there is multiple fracture, if the frontal bone is fractured, there is comminuted fracture, then you have to go from bicoronal approach. Otherwise, you can give the local incision. One is called lateral eyebrow incision. In case of lateral eyebrow approach, incision is given at the just above the zygomatic of frontal suture. You have to give incision in this area. In the lateral eyebrow area, you have to expose the you have to explore the fracture fragment. You have to raise the mucoperiosteal flap. You have to incise the skin, then subcutaneous tissue, then the periosteum. Once the periosteum is incised, you have to raise your periosteum. Once the fracture is explored, you have to reduce and you can fix it with a 1.5 mm plate and screw. Other approach is subciliary approach or infravital approach. Infravital approach, in case of infravital approach, the infravital incision is given at the region in the area of the infravital rim. The problem with this approach is there will be aesthetic problem is there because you will leave the scar mark. Under is subciliary approach. Subciliary approach is given just 2 to 5 mm below the margin of the lower eyelid, where the incision is given just below the eyelashes. The significance of this incision is, even though the scar mark is formed in this area, but it can be hidden by the lower eyelashes. So the incision given just below the eyelashes is known as subciliary approach. In case of subciliary approach, you have to give the skin incision, then followed by the muscles which is present in the orbicularis. You have to incise the orbicularis oculi muscle, then you will raise the bone. You have to incise the periosteum just below the infravital rim, because if you give the incision in this area, there is presence of periorbital fat. This periorbital fat will come into your surgical site and it will interfere with your surgery. So it is also known as a step incision. If you notice the incision, you have given the incision just below the eyelashes in the skin. Few millimeters, about 5 mm below, you have given the incision over the orbicularis oculi muscles. Again, after raising your orbicularis oculi muscles, you have to incise the periosteum just below the infraorbital rim. So once you reach the rim, then you can explore the infraorbital floor and you can do the reconstruction of orbital floor in case of orbital floor fracture. The other significance of this step incision is the scar mark is very less. There will not be big scar. If you give the incision at the same area, there will form the big scar mark in this area. So if you give the step incision, the scar mark is very small. And another thing is the periorbital fat which is present around the orbit or around the eye globe will not be extruded in your surgical area. Another instrument is Carroll-Girard screw. It is used for the elevation of the zygomatic bone. This is Carroll-Girard screw. If the your zygomatic bone is fractured, if it is placed either medially or laterally, or most of the time it is displaced downward due to the contraction of masseter muscle. The masseter muscle is attached to the zygomatic bone, zygomatic arch. So due to the contraction of the zygomatic bone, it may be displaced inferiorly. So for reduction, you can use the Carroll-Girard bone screw. Carroll-Girard bone screw is inserted into the body of the zygoma and it can be reduced and fixed. So the Carroll-Girard bone screw is used to reduce the zygomatic maxillary complex fracture. They might ask, or I think they have asked sometimes, Carroll-Girard bone screw. The Carroll-Girard bone screw is used to reduce the fractured zygomatic bone. Another instrument which is used to reduce the zygomatic bone is J-hook. Instrumentation reduction technique for ZMC fracture. Stromeyer bone hook. It is known as Stromeyer bone hook for percutaneous elevation. Carroll-Girard bone screw inserted in the zygomatic body. In case of Carroll-Girard screw, it is inserted in the zygomatic body. In case of this Stromeyer bone hook, it is placed just below the zygomatic bone and it is used to elevate the depressed zygomatic bone fracture. Okay, we'll discuss the method of fixation in next class. And I will be taking all the classes of this week and hope we will complete all the surgery part in this week. For surgery, we have 10 classes. Today is 5th week. Still there are 5 classes remaining and we'll complete all the classes till Friday. So I will take all the classes in the morning in this week, okay, instead of an alternate day.